Hi, everyone. Good evening. This is Elizabeth here, one of the travel nurses from CNY Fertility's global travel team. And I'm just here for our Monday night chat. Tonight's going to be just a little bit low key in terms of I'm hoping to address a lot more questions tonight. I know I tend to get on my soapboxes, and a lot of you come to view these in order to get your questions answered. And so I'm hoping tonight to be a resource in terms of getting specific questions answered that you might have or that you're wondering about. So while people join, again, my name's Elizabeth. I'm one of the travel nurses here at CNY Fertility, and our team, the global travel team, supports all of our clients thank you, Kelly, supports all of our clients that are traveling to CNY Fertility. Most of those are clients that live about an hour away, but in general, anybody who's going to do monitoring outside of one of our offices before they get to CNY Fertility is considered a travel patient. So every now and then we have clients that are only travel clients once or twice. Maybe you have a work trip planned and you're a local Syracuse client or local Colorado client, and you have a work trip plan and maybe you need to get your midway labs at an outside lab. That would mean that, the travel team would help you that day. But I'm hoping to just kind of help explain our process as the travel team, because I think the more that you know about how the travel team works and operates will help empower you to make sure that you have the best cycle possible. So, okay. Oh, Kelly likes how quickly we answer your questions. I'm so happy. Sometimes we would love to answer them quicker than we do sometimes, but there's a lot. So we do our very best. I'm glad that we're being able to be helpful. So, okay. So tonight's going to kind of be, I'm going to spend about 10 minutes here in the beginning talking about monitoring and what it is, what we're looking for, why it's important. And then as soon as I kind of wrap that up, we'll just answer questions. So feel free, if you have questions now, feel free to drop them in the comments. And then when I'm done with my little monitoring spiel, I'll kind of start at the top and answer questions. So monitoring, what is it? Why is it important? Every cycle that you go through, so there's a set of, once you become our client, we have you go for some labs that we call preconception labs, and they're just to make sure that we have a good baseline, make sure that there's no glaring medical issues that we need to address prior to you starting treatment. And as a general rule, there's nothing that's necessarily going to be something that would stop you from doing treatment. There are things that sometimes kind of put the brakes on, but rarely do we say, no, you cannot, you cannot proceed. It's usually more of, hey, we want you to start this supplement or see your PCP about this or that. So once you've done all of your preconception testing, the next thing that happens is you will call the office. You can also message the office to let us know that you've begun your menstrual period. And so we consider day one, that first day of full flow, bright red, that's your first day. So spotting does not count. It's that full flow that we're looking for. And that's what we call cycle day one. So like I mentioned, you can call the office or you can message the travel team. If you're a travel patient, you can message us through the patient portal. You will notice there are a couple options for travel team. And off the top of my head, I can think of three. There's one that's for general questions, and that one's called Global Travel and then questions at the end. There's one that's specific for cycle day one notifications, and I believe that's exactly what the inbox is called, is cycle day one notifications. And so by routing your question to the right inbox, it just helps us get to your question and help analyze that and get that answered sooner. So for example, there's a lot of times on weekends, we'll go first to those cycle day one notifications because we want to make sure that we get you scheduled for Monday or Tuesday, whatever the case may be. So definitely try to direct your questions to the correct inbox. So there's the question inbox, there's the cycle day one notifications, or I think it also says lab requisitions. So if you're needing a lab order for something, maybe we gave you your midway orders and you've lost them and you can't find them in your portal or something like that. Maybe the nurse who helped you with your last set of results told you to go back on a certain day and that lab order for some reason isn't showing up. It happens from time to time. So that would be a place you could direct those questions. So questions, lab upload or lab recs / cycle day 1. And then there is actually a specific inbox that says global travel results uploads. And we're going to talk about this in a minute, but if you upload results or you have results, you would want to message that inbox. So back to cycle day 1, you're going to notify us either by calling the office or by sending a message through the portal to Global Travel Cycle Day 1 notifications, and just simply state that you are cycle day 1, or if you weren't able to get to us for some reason on cycle day 1, I'm cycle day 2, whatever the case may be. And then at that point, we will write you back and let you know what day you need to go for baselines. And baseline ultrasounds and labs are important because they give us a frame of reference as we go through the cycle. Can you start without baselines? You could, but you would be risking that those baseline that your cycle would potentially be clouded by something popping up on a subsequent ultrasound that we weren't expecting. And so a good example of that is, let's say, we understand that cost is a huge consideration for everybody. And so you might say, look, it's going to be $300 cheaper for me to skip baselines. Can I skip them? If you ask to skip baselines, we'll tell you you can. But the risk of doing so is that, like I said, as we progress through the cycle, something pops up that because we didn't know it was there at baseline, we kind of don't know what to make of it. And an example of this would be, let's say your baseline for an IVF cycle and you decide to skip baselines, you start meds, and we send you back for your first monitoring visit and you've got an 18 millimeter follicle. Well, the problem without the baselines is we don't know if that follicle was there at baseline or not. We don't know if it's a growing, developing follicle with an egg in it or if it's a cyst. Unfortunately, ultrasound can't really tell the difference between the two sometimes. If it's a hemorrhagic cyst, which means a collapsing cyst that was ovulated, that can sometimes be detected on ultrasound, but not always. And because many of our clients do have to rely on outpatient radiology clinics, basically anybody other than a fertility center who does hundreds of thousands of ultrasounds a year and knows what those hemorrhagic cysts look like, then we see that 18 millimeter and we don't kind of know what we're looking at, and it clouds the picture. Without those baseline labs, let's say you went for baseline and we saw a 16 millimeter follicle there, or what we thought was a follicle, but we saw your estrogen was extremely elevated. Let's say it was 300. That's a really good indication. Those two pieces of information are a very good indication that maybe not best to start. And obviously each individual situation is going to be analyzed and decided on in its own bubble. But we want to make sure that we give you all of the information so that you have a successful cycle. And by not having baseline ultrasounds and labs, it can be a little bit unclear. And so again, we'll always let you kind of skip those baseline labs if you ask us, or those baseline ultrasound if you ask us. But I do believe you're somewhat putting yourself at a disadvantage because, like I said, we don't necessarily know what we're dealing with. And so that's kind of the idea behind that. So I just noticed that I am live on Dr. Keltz's Facebook page, but not the regular Facebook page. So bear with me for just 1 second while I fix that, because I was wondering why there were so few people on with us, and that seems to be the reason why. So I'm just trying to add in the regular Facebook page, and hopefully it looks like we're going to be live there in just a second. So Facebook, Hi, everybody. I apologize. I've been live for about 5 minutes now, but I just discovered that I was broadcasting on Dr. Kiltz's Facebook page and not on the main CNY Fertility Facebook page. So hopefully we'll get some people, some other people that are used to seeing us on our main Facebook page kind of jumping in. And so to back up for just a hair here, tonight we're talking, primarily we're going to do questions. It looks like I've already been talking for 10 minutes, so question time will come. But we're talking primarily tonight about monitoring and why it's important. So we were just talking about baseline monitoring and why it's important not to skip that if you ask us if you're allowed to skip it, of course, this is your body, your money, your time, your meds. And so if you choose to skip baselines, that is 100% your right. But it does just sometimes cloud the picture of what we're looking at as we go along. You go for baselines and we see a big follicle, then we kind of know what we're dealing with and we can make our best judgments as we move forward. And so that's kind of what we were talking about. We will get to those questions soon, but let's just kind of finish up this little section on monitoring because we have a whole team of medical assistants and staff that are dedicated to processing, for lack of a better word, your results. And so they will, they manage all of the faxes that come in. So if you were on our outpatient schedule today, you might have heard we had, some frustration with our fax machine, and that happens. It's technology. We have to roll with it. We have to do the best we can with it. But we have a whole team of staff that are dedicated to getting your results and processing them. And so it's really important for you to, one, you're going to notify us of cycle day 1. And we talked about this a little bit before, but I realized they've brought some new people on with us. But you're going to notify us of cycle day 1, and we're going to let you know what day to go for baselines. At that time, we're going to place you on our outpatient schedule. So if you look in your patient portal, under, I believe it says appointments, and you see it usually for the travel schedule, it usually defaults to Syracuse. So you might think, oh no, do they think I have an appointment in Syracuse today? No, we don't. We know that you're going outpatient, which is why we give you an order. But the reason we place you on our schedule is because that is our mechanism to make sure that we get your results. And so what happens is if we have 50 clients scheduled on the outpatient schedule on a day, and we have 10 nurses, and this is just an example for easy math, then the five clients apiece would be assigned to each of those 10 nurses, so that nurse then becomes responsible for reviewing your results and getting you a plan. And so if we don't know you're going, what happens is you become what we call an add-on. So if we don't know you're going, your results, if they come in on their own, so a lot of times results do not, I wish they did, but they don't always come in on their own. And that's where that team of our wonderful, we call them our results team, that's where they come in, which is to call your facility and say, hey, we're still looking for results on Terry White's. Can you call for those, or can you fax those? If we don't know that you're going, Terry, then we don't know to call your facility. But another really important thing is, and I want you all to jot this down, that is that results upload inbox in the patient portal. It says Global Travel Results Uploads. That is a fantastic place to just the night before your monitoring visit, send them a message, even if you go to the same exact monitoring facility every single time you go. Not everybody does. And so some people, you might find that you wake up in the morning and there's a message in your inbox from our results team that says, hey, what time is your appointment and where are you going? And you might think to yourself, well, gosh, I go to the same place every time. Do they not care enough to look? And let me assure you that is not it. However, a lot of people aren't able to get into their monitoring facility on the day we ask them to go. And so if you've heard any of my chats before, I encourage people to have a backup facility for their ultrasounds and their labs if possible. And I understand, I grew up in a rural area, so I understand that that's not possible for some people. But where possible, having that backup facility just helps in the event that we ask you to go on a certain day and your primary facility is not able to get you in, then you don't have to stress. You can just pick up your phone and say, hey, to the backup facility, can you get me in? Great. And then we go from there. And so get into the habit, happy Monday, Kimberly, get into the habit of just being proactive. I always say it's better to over communicate than under communicate. So if you're going to your facility, let's say we ask everybody to go and make sure that we get your results by 2:30 p.m. Eastern time. And so let's say, for example, that we asked you to go today and your facility, USA Diagnostic Imaging, could only get you in at 1:30 and you're worried that we might not get your results by 2:30. Send us a message. Send that message to Global Travel Results Uploads and just say, hey, I'm actually not going till 1:30 today. I'm going to my normal place and their phone number is this, and their, the lab I'm going to is this, and this is their phone number. It's 30 seconds of your time, but it truly does help our results team to process your results as fast as we can by making those phone calls. And by knowing the time that you're going, we can sort of organize our day and make sure that we're on top of getting your results. There is nobody that wants your results worse than you do, other than maybe us. And because we know that you're in your area anxiously awaiting a phone call with your plan. And we can't give you that plan usually without your results. And if we do give you a plan without results, it's because we just didn't get them in time. But obviously that's not ideal. And so, that's kind of my spiel about the results. So let us know where you're going, especially if that place changes. And by sending that message the night before, and you can also send it to our email address, which is globaltravel@cnyfertility.com. And that email address is at the top of every single one of your requisitions. And so if you want to just jot down in a quick email, maybe you don't want to get on the patient portal or you don't have time or whatever, send us an email. Make sure you give us your name and date of birth, because if your email is princesscharlotte@hotmail.com, we're going to have a hard time determining who that is from. So shoot us a quick email and say name, date of birth, and I'm going to this facility at this time and this facility at this time. It really, truly does make our job so much easier. And then the other kind of quick thing I wanted to bring to everybody's attention, and I mentioned this at the very beginning, but as I said, there were some people that I got on a little bit late because of my error on this side. But if you upload your results, we love that. That's great. You can upload them to your patient portal, or you can email them, which is generally preferred. And the reason it's preferred is because the uploads, unfortunately, it does not notify us as a team that you uploaded results. And so if you don't tell us that they're there, then we don't know to go look for them. And so it causes some frustration in that you say, well, I uploaded my results 5 hours ago. Why has nobody called me? It's because we didn't know they were there. And so if you do happen to upload your results, please send a message to that Global Travel Uploads web correspondence inbox, or email us at globaltravel@cnyfertility.com and just let us know you uploaded them. Now, quick little asterisk there is, please do not use the globaltravel@cnyfertility.com email address to correspond with us about your care, because the web correspondence system feeds all of those messages into your chart so that we can accurately keep track of your care. And so obviously a super quick question through email is one thing, but as a general rule, if you're asking medical questions through the email, we're going to probably reply to you through the patient portal so that we can kind of direct traffic back that direction. And so if you upload stuff, make sure you tell us. Definitely, if you can get into the habit of the night before you go, just sending a message to that results uploads with the time you're going, the facility you're going to, and then the phone number, that would be just wonderful, because that will help us just get your results quicker and get you a plan quicker, which is what we know we're all trying to do. And like I said, you will be scheduled on our outpatient schedule. So if we don't know you're going, there's a couple of of issues. One, remember, we place you on our outpatient schedule so that we can assign a nurse to your care. And our nurses, I can truly and completely say without a shadow of a doubt that the nurses at CNY Fertility are the most dedicated nurses I have ever worked with in my life. I've been an IVF nurse for about 6 years. Prior to that, I did labor and delivery, perinatal bereavement, and prior to that, it was a cardiac nurse. And I can tell you without a shadow of a doubt that this is the most dedicated, kind, caring group of nurses that you will ever work with. And so that many of our nurses, they take their own time the night before when they see what their assignment, so to speak, for the next day is going to be. And they research your chart. They research what you've been through. They research your past cycles. And they come together with the plan. They're researching your last consultation, the reason for your treatment, all of these things they're researching, they're putting them together so that they can give you a really solid plan the next day. But if we don't know you're going, we can't place you with a specific nurse and then you become kind of an extra for the day, which is fine. We will always get you taken care of. But what is really unfortunate is when we don't know you're going, like I said, we don't know to track down your results. And then what can sometimes happen is you call us at 5:15 frantic that the office is closed and we haven't given you a plan. Well, that's because we didn't get your results. We didn't know you're going. Devin asks an excellent question, which I want to just kind of break to answer. And that is, she asks, can we just get a reply button? That's the only thing that needs fixing. And Devin, girl, you are not the only one to ask us for a reply button. Sadly, the software that we use for the medical chart does not have that as an option. So it's not that I was just adjusting that. It's not that we're trying to be difficult. It's just that it does not exist. And so rest assured that that we can see your prior communication. And so I apologize. I know it's frustrating, but it just doesn't exist. We do not have it. In the software, it doesn't exist. So I know that's frustrating and I'm sorry. We certainly don't want to be adding frustration, but real quick, back to what I was talking about, and then I'll make a few more points and then we're going to answer questions because that's what I promised we would do. So if we don't know you're going, you don't have the luxury of having a nurse who is looking into your chart the night before, early in the morning, and coming up with your plan. And then also, if we don't get those results till late, then we're kind of behind the 8 ball in that regard. And so the last thing I kind of wanted to mention was we talked about baselines and why they're important. And the primary reason that they're important is just to make sure that we do know where we're starting from. And that way, a lot of times we can't make true sense of the results with no baselines because we can't exactly correlate what's happening now with what was there at baseline. Same with your lab results. We don't necessarily know if you decide that you want to skip your baseline for your FET, let's say your frozen embryo transfer. We don't know that your lining adequately thinned out. So if you have your menstrual cycle, we're looking to make sure that that old lining went away. It all shed off through the bleeding process. And that now what we're starting with is fresh, nutrient-dense lining to support a pregnancy. So if you skip your baselines for your transfer and you go back for your lining check and your lining is a 9, we don't know that it wasn't a 9 at baseline. We don't know that it's not fresh, nutrient-dense lining. And so we could be booking your transfer at the wrong time. Same with your or not your lining thickness, but your number of follicles. We don't know what was there at baseline, so we don't necessarily know what to expect. And so each of your orders will have, you will see what's required or what's being requested. And those labs are being used for a specific reason to correlate with what we see next. And so it's very important for your baseline to include the estrogen, the progesterone, the luteinizing hormone, your thyroid level, your TSH, your FSH, and your HCG. And some people get frustrated with us for asking for an HCG, but there's a very specific reason we ask for it, and that is we want to make sure that we don't harm you with the medications if you were to somehow be pregnant. I spoke with a lovely client today who stated that she had tried cycle after cycle after cycle, and they decided to just take a break for a little while because they just weren't getting anywhere, and they just mentally and physically needed a break. And she ended up getting pregnant on her own and didn't even really realize it till 8 weeks because she was just so much in this mindset that, no, I'm not pregnant. No, I'm not pregnant. There's no possible way I can be pregnant. I've tried everything. I'm not pregnant. But we want that baseline HCG there to show that it is safe to proceed. And it's a requirement for if you're doing a retrieval. We have to show certain auditing bodies that we did show that HCG was negative at baseline. And so I do want to just encourage everybody that I know that this is so expensive. It's so time consuming. It's so frustrating even to have to see that beta is negative, even though it's baseline, I know is devastating to some people. And so there is a really good reason that we ask for each and everything that we ask for. And so then my last thing I'm going to say about monitoring, and then we'll go answer questions. And that is that when you go for your baseline for IVF, it's really important that they tell us how many follicles are on each ovary. They don't necessarily need to give us the sizes of the follicles. Let's say there's 5 on each side. As long as we know that they've given us the sizes under a centimeter, that's sufficient. However, when you go back for monitoring, once you've started those stimulation meds, we really want to know the sizes of each of those follicles that's above a centimeter. Sometimes we see maybe about 30% of the time, I'm making that number up, but it's probably somewhere about there. We see that centers will only want to report the largest 3 follicles on each side. And the reason that that's problematic is that if we don't know, let's say you have 3 follicles on each side that are 16 millimeters. So you've got 3 16s on the left and 3 16s on the right. Most of the time, if that's all that was there, we would be talking about trigger. We would be having a trigger conversation. But if you've got 3 16s on each side and you've got 10 more on each side that are 12, then we could be triggering too soon because sometimes we don't know, if we don't know what's coming up or we don't know what's growing, then we might just look at that picture of what is mature. And so that's the important thing with knowing all the follicle sizes is we're going to look at the big picture and see, okay, yes, there are 6 follicles that are 16, but there's another 20 follicles or 10 or whatever my math turns out to be that aren't quite ready yet, that if we gave 2 more days, we might be able to retrieve a whole bunch more eggs, I guess is the point. And so at baseline, just the number of follicles. We do want to know those that are above 10 always. That's very important. And then for FET, for your transfer, if you're doing a frozen transfer, it's important just to know that lining thickness and then any follicles that are above a centimeter. A lot of our clients will write to us and they'll say, I don't understand. Either I'm using donor eggs or I'm doing an FET or any number of reasons. Why do you want the follicles? Well, even if you're using donor eggs, if you have a follicle that's developing, and let's say it's 16 millimeters at your lining check, as the nurse, I am aware that that follicle is going to be at risk for ovulation soon. And if you ovulate before we start your progesterone, your transfer is not going to work. And so my big point in all of this is just to know that there is a reason that we are asking for each individual thing that we're asking for. And so each one of those items that's missing from your report just sort of gives us a little bit less clarity in terms of what we're looking at. And then the very last thing I'll say, and then I promise I'll start at the top and start answering a couple of questions, is just that very, 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 very important. If you are doing a transfer, we really would like to know the type the pattern or the lining type. So your two choices, well, I suppose there's three. There's three choices. It's either going to be homogeneous, which means the whole lining itself it all looks uniform. There's intermediate, which is sort of a midway between all kind of uniform and starting to develop. And then there's that third thing, which is trilaminar. And a couple of weeks ago, somebody pointed out, which I thought was wonderful, but that my painting behind me sort of resembles a trilaminar lining. And I suppose it does in the sense that if this is the uterus, this white sort of bright line in the middle is that trilaminar. So tri meaning three, laminar meaning stripe. There's three stripes. And that's kind of telling us that the uterine lining is differentiating into a nice vasculature that is supportive of early pregnancy. And so if you go back for your lining check and your lining is 7, but it's homogeneous, meaning it hasn't developed this nice texture, we might say, well, we could schedule. People do achieve pregnancy with homogeneous linings. So we could schedule, or we could say, well, let's take another couple of days and see if we can allow that lining to develop into that trilaminar pattern that we're looking for. And so once again, if I could impress anything upon you tonight in terms of monitoring, it's just that that everything that we ask for on your monitoring there's a reason why it's important, and there's a reason we ask for it. So let's answer some questions. Van says, what vitamins help for men's sperm count? He is on carnivore, I'm assuming carnivore diet for 2 months now. So that's fantastic. That's going to make a positive difference. The life cycle of sperm and eggs is somewhere about 90 days. So we know that what we do today is going to affect our eggs or our sperm 90 days down the road. To carnivore diet is we have a wonderful line of fertility supplements there. We have men's supplements, women's supplements. We have all kinds. If you check out molecularfertility.com, that's a great place to go to check out some vitamins and supplements that can be helpful for male fertility. Ooh, this is a nice long one. So Kelly says, I was going to say this is probably going to make my face disappear. She says she's priming for about 80 days with Omnitrope, but today is day 4, planning to start stim end of June, beginning of July. She has some inflammation due to Hashimoto's. That's a thyroid condition. Not on any thyroid, but that may change. Global team said I could start LDN now. Which does help, but wondering things like aspirin, Claritin, Benadryl, lipids, and if you should start those while priming. AMH is 0.229. Okay, so this is a great question. I'm going to hide it so that my face comes back into view. But Kelly, so I just said, right? We know that what we do today affects our eggs and sperm. So in your case, eggs 90 days down the line. So I really appreciate when we recommend priming for 30, 60, 90 days and a client says, okay, because sometimes, a client will ask me, well, what if I prime for two weeks? That's great. That's better than no weeks. But it certainly may not be that full-fledged approach that we're looking for to impact our eggs down the line. So your basic question is, what can you do now to add to priming? So I'm assuming you said Omnitrope and LDN. In addition to those two, I have not heard of anybody adding things like aspirin, Claritin, Benadryl now. But with that, what I will say is if, and I do not take anything I say as direct medical advice for your specific case. So, but in general, I would say that the antihistamine protocol. So we do know that overactive histamine in our body can create situations with inflammation. And so the Benadryl, Claritin, Pepcid regimen is really quite good for anybody who suspects that they have high levels of histamine. And so that really could be an interesting protocol to add on. And so if you're interested in the details of the antihistamine protocol, just send us a message through the patient portal and we can kind of spell it out for you. So, antihistamines, I think antihistamine protocol, great idea. Why do we use aspirin? Primarily to act as a little bit of a blood thinner so that as you're developing and becoming pregnant, that microscopic placenta, which is just a network of tiny, tiny little blood vessels, doesn't become clogged with a microscopic blood clot. So just off the cuff here, I don't necessarily see a reason for adding baby aspirin now. But with that said, you could check with your PCP if you don't have any contraindications to using aspirin. It is an over-the-counter item that could potentially have benefit. Intralipids, those are acting specifically on natural killer cell activity in the uterus. And so I don't really see that those would be beneficial to you in terms of priming. But the other thing that we recommend a lot if you're not taking currently is Ovarian Bloom, which is a compilation of supplements through our molecular fertility line, which focuses on ovarian health. And then also there's a supplement through Theralogics called Ovasitol. It's spelled Ovasitol. And that one is really good for balancing out the hormones and lowering your insulin resistance. And so many of our providers do recommend priming with Ovasitol. So I think those are some options that you could potentially look at adding. Omnitrope and LDN you've got going. Hopefully you're already taking high quality supplements like vitamin E, vitamin D, vitamin C, fish oil, CoQ10, DHEA. But specifically for you, ask in the patient portal and we can look into, specifically what you've got going on and if there's anything else we can think of. But I'm so happy to hear that you're dedicated to priming for those 80 days because I really think that will make a big difference. Dana asks, if I had a polyp removed from my uterus in October, is it required to have an SIS, which stands for saline infused sonogram, or another HSG? I went for a checkup after the procedure and was told that everything looks good. So very happy to hear that polyp was discovered and resolved. But with that, I would say the following, and that is that here at CNY Fertility, like I mentioned before, we don't tell you what you have to do because we believe that this is your body, your money, your time, and that you should be able to have that choice in what you do. With that said, many fertility centers require a saline sonogram or a uterine cavity assessment every 6 months in order to just double check and make sure that there's nothing in there that could preclude us from having a successful cycle. And so while I would say, is it required? No. Is it potentially beneficial? I think it is, because especially if you've had a polyp prior, what's to say another one hasn't cropped up? And so the presence of a polyp in the uterus becomes problematic because embryos tend to take the path of least resistance. And so if there is a polyp right at that tip of your uterus, the fundus of your uterus, and we place the embryo right there, that embryo is going to attempt to attach and implant sort of in or on the polyp, which doesn't have its own blood supply and nutrients to support a pregnancy. And so again, not required, but highly beneficial, especially given that you do have a history of polyps. I hope that's helpful. Let's see here. Who else has questions? What about baselines for an FET when you're on Lupron to suppress? Still important, because while Lupron suppresses the ovarian hormones, there's still a potential that your lining is thick. And so, if your lining is thicker than about 8 millimeters on baseline, we start to worry. Again, not necessarily, but we might worry that lining hasn't fully shed, and thus then we'll be building up new lining, but that sort of area that didn't shed the month before is going to be what's right on the inside where that embryo is going to implant. And so I would say for baseline, even if you're on Lupron to suppress, baseline monitoring ultrasound is very important. Okay. Let's see here. So Destiny has a wonderful question, one that we get all the time. So she says, I did a transfer last Tuesday. My progesterone was 40 and now it's 29. And estradiol was 709 and now it's 157. Is it okay? I'm worried that something's wrong. So Destiny, I completely and 100% empathize with that question, because when we see any type of fluctuations, we start to worry. well, why was it so high last week and now it's so low? And what I would tell you is that those fluctuations are 100% normal and expected. I don't know what the details of your specific cycle were, if you did a fresh transfer or what the specifics are, but the research is very clear that as long as estrogen remains above 100 and progesterone remains above, it's usually above 10 for a fresh transfer or above 20 for a frozen transfer, then that is a sufficient amount of hormone to support a developing pregnancy. And so just know that it is very, very, very normal for those estrogen and progesterone levels to fluctuate. And while nerve-wracking for you, completely normal and truly and completely nothing to worry about. So I for one am crossing fingers and toes that is going to be a positive beta as soon as it would be if you just did midways, and you're not too far off. So hopefully that turns out wonderfully for you. Silvana has the question, is the Buffalo facility open? And the answer is yes, it is. So the Buffalo facility is a little smaller in terms of our lab capacities. And so if you are wanting to go to Buffalo, there might be an instance where we might have to delay your start date by a couple of days just to make sure that we don't overwhelm their lab. But yes, the Buffalo office is open and actively doing retrievals and transfers as well as everything else that they've always done. And the only thing I would say is that at the current moment, Buffalo is not doing those cycles that involve genetic testing or PGT. And so if you did want to do PGT, what we could have you do is retrieve in one of the other offices, have your embryos tested and frozen, and then you could always have them moved to Buffalo. There is a small fee, just obviously we have to ship them, but you could have them moved to Buffalo for transfer. Okay, Terry is asking a question that I get a lot, and that is, if the amount of estrogen is different from the ERA results, can the new dose change your window? And so I'm pretty sure I understand your question. And if I get it wrong, I apologize. But I think you're saying that if you aren't on the same amount of estrogen and or your estrogen levels, your blood levels are different, is that going to affect your window? And the answer is no. So the two most important things about an ERA cycle are, one, that the cycle itself, the ERA cycle, the cycle that gave us that number of hours that in which you were progesterone receptive, if that type of cycle and those results were based on a natural cycle where you ovulated, then your transfer has to be mapped out the same way, meaning that we need to build up a follicle, trigger it, have you ovulate, and then base those hours of progesterone on those ERA results. Whereas if you did a medicated cycle where you started estrogen from the beginning, and then once your lining was adequate, you started progesterone and we did the ERA, then that has to be translated to the transfer cycle itself, meaning that you wouldn't want to do a medicated ERA cycle and then try to do a natural FET. That would not work. But as far as everything else, the levels do not matter. If your lining thickness is different, it does not matter. It's the overall cellular receptivity to progesterone that matters. And so let's say you do an ERA cycle with estrace orally, and you come back for your FET cycle, and we have to add a tablet vaginally because for whatever reason your lining's not responding, does not change the window of implantation. So I hope that was helpful to you. Okay, let's see here. Jane is asking, just wanting to know how much meds can mess up my cycle. Always had normal cycles. I'm in limbo here waiting for FET, no cycle starting. Totally and completely common and frustrating as all get out, but very common, that the fertility medications, I tell folks a lot who maybe are baseline for IVF and they start saying, well, I want to do a frozen transfer. When is my transfer going to take place? My period's supposed to start next month on X date. And I say, well, unfortunately, we have kind of monkeyed with that. So it's not uncommon at all for the fertility medications to kind of monkey with your cycle. So I think you were saying, No cycles starting line if you think I'm a retrieval in February. So I would say let's send you for a baseline ultrasound and lab work to see where things are, because there are times where all those hormones will be nice and low, but a cycle never starts because you didn't ovulate. And so everything's just kind of hanging out. So it's not uncommon that we send you for like a diagnostic ultrasound and labs and discover that no period is coming anytime soon. It's safe to start. So Nicole is asking, having an ERA next month with monitoring clinic, just message the travel team. That's exactly right, Nicole. So if you want to make sure that you double check with your monitoring facility, one, that they have the knowledge of what the ERA is, so that they understand that it's done with a very specific company. The company name is iGenomics, and they will need a physical kit from iGenomics to process your sample. And so I would just say, if you're not sure whether they know kind of what they're getting into or what they're saying yes to, we can always upload to your chart where it's like a little referral card, and it will give your facility everything they need to accurately process the extract the sample from the urine lining and process it and all of that. So just make sure, like I said, just make sure that they really do know what they're doing, because you wouldn't want to, you wouldn't want to go through the whole cycle and then come to find out, that they aren't capable of doing the cycle. So, and then also we want to, once you call with cycle day 1 and you actually go for baselines, we'll actually notify iGenomics that you're our client, just to make sure that the results ultimately come back to us. Megan is asking, if we're in the middle of stims and have a question after hours, will we have a specific number that we can reach out to? So the answer is yes. We do have our clinical team of nurses answer our phone lines until 8 p.m. After 8 p.m., we do have an on-call nurse that's available 24/7. That line is really for emergencies. And so we do ask that you don't call the on-call nurse and ask for a refill for something that, you have a day or two to wait on or something like that. But we are here 24/7. And I do think it's important to note as well, Megan, that if your question is medication related, the fertility pharmacies also have 24/7 on-call support. So between us and the pharmacies, you should be able to get your after-hours questions answered. So I hope that helps. Let's see here. Reggie is asking, I have 4 follicles and 6 cysts. Okay. 3 and 3. I'm not sure what you mean by that. Is it convenient to start baselines or better wait till the next cycle? Truly depends on kind of what your labs look like. And, I'd have to kind of look at the whole picture of what your AMH is. And if 4 follicles is kind of what we expect from you, then yeah, I would say let's go ahead and get started. Whereas if normally on previous cycles, let's say your AMH is 3 and you've always had 10 on each side, then maybe those cysts are inhibiting ovarian development and it might be better to wait. Well, Erin, this isn't a question, but I'm just sharing it because it's so sweet of you to say that you're waiting on your cycle day 1. And so far we've been amazing. I'm so happy to hear that. We really, like I mentioned before, we really has the best nurses I have ever worked with in my entire life. So I'm really happy to hear that we have been supporting you so far. Let's see here. Destiny, we talked about your midway labs. Devin, we talked about your reply button. I'm so sorry. Nefertiti says, I had Bree at the Albany office for my retrieval last month, and she was the best nurse she's had ever. I'm just going to write that down and let her know, because we always appreciate those kind words. We all work tirelessly for you all, for your for your success. And so we really appreciate you sharing those things with us. All right. So Terry is saying, I did 2 milligrams of estrase, 1 POBID with my ERA. Okay. So we kind of talked about this a little bit earlier, I believe. If you did estrase 1 by mouth twice a day, and that was enough to kind of bulk up your lining, we can try that again. We absolutely can. But changing to TID or 3 times a day will not change your receptivity window. Trey has a question. Can I have my intralipid shipped to the Albany office? Absolutely. You can have your, we don't necessarily request that that you ship your whole medication order to us unless there's some kind of extenuating circumstance. Because as you can imagine, if we had hundreds and hundreds of people's big boxes of medication shipped to the office, we might have trouble storing it all. But yes, 100%. If you've got an HCG wash or intralipids coming up and your timeline is kind of close, absolutely have those shipped to the office. That is not a problem at all. All right. So Jessica was asking, is it common to have follicles that are bigger than a centimeter, but that they don't have an egg in them? No, that's pretty uncommon. So there is an anomaly of follicular development called empty follicle syndrome, where we can see on ultrasound all these big, beautiful follicles, but we go to extract them and there's nothing there. That's pretty uncommon. I actually got a question about this today with one of my clients, and I personally, by no means the expert, but I have seen empty follicle syndrome a few times in my 6+ year fertility nurse career. So empty follicle syndrome is pretty unusual. Not to say that couldn't be your case, but it's pretty uncommon to have follicles greater than a centimeter without an egg inside. So definitely rest assured that we will be keeping an eye on everything. And also, something important to note is we're also tracking the development of the follicles with your estrogen level. So as the follicles develop and grow, they're secreting estrogen. And so kind of again, when I mention that we're asking for very specific things on specific days for specific reasons, one of the reasons we ask for the estrogen is because we're trying to correlate that estrogen number with the number of follicles we see. Because let's say that you had 10 follicles that were all 12 millimeters, but your estrogen, you didn't take letrozole. So letrozole is known to depress that estrogen level. But let's say your estrogen was only 100. Then that might be an indication that those follicles were not growing an egg. So, but that's, one of the many reasons that we ask for the things that we ask about. So, because all of the data that we ask for has a purpose. Talisha was saying, should we see our regular PCP to speak about IVF medications and continuing our current daily medications? That is such a fantastic question. I believe truly and completely that everybody should see their PCP before they start IVF, just for a well check, just for I guess as they don't call it a well check as an adult, but just as an annual physical. But yes, it's very important to see your providers. So let's say you're on blood pressure medication or anxiety medication or any number of other types of medications. I think it's very important to consult with the provider that prescribed that, just to let them know, I'm trying to get pregnant. What is the implication of taking this medication in pregnancy? Would it be better to get on an alternative? So by establishing those things beforehand, it just helps there to be less stress and less sort of confusion during the process. So that's an excellent question. Next question, I think we'll have time for just a few more here. So Giselle asks, hi, so excited to start IVF, waiting on my cycle. I'm 31 years old and would like to transfer 2 embryos. Is this possible? And if so, is there any extra charge? So I'll answer the very end question first, which is there any extra charge? Not that I know of. However, financial questions should always be directed to our financial team. With that said, the number of embryos to transfer is a very controversial question. And we deal with this question every day. So there is a body that I wouldn't call it necessarily our governing body, but there's a body that we follow guidelines from, and it's called the ASRM, or the American Society for Reproductive Medicine. And they have set forth a set of guidelines on the number of embryos to transfer. And that guideline, or that ultimately comes down to a couple of things. One is the age of the eggs. And so if you're 31 years old, for the most part, the guidelines are going to say we should transfer 1. And there's a very good reason for that. And that reason is that transferring 2 embryos does not double your chances of success, but it does double the chance that if you're successful, it's going to be with twins. So that all the way back in fertility history, the reason for transferring 2 embryos is just to essentially increase the chances that at least one of those embryos is going to be strong and healthy enough to implant. We know we all make embryos that maybe aren't healthy from a genetic perspective. And so the idea behind it is to increase your odds that one of them will stick. But if you're 31 years old, the statistics are pretty clear that genetically, you should have a certain percentage of embryos that are genetically normal. And so actually, by transferring them 2 at a time, you oftentimes lessen your overall chances because you give yourself less overall chances to try. So with all of that said, If we counsel you on the risks and you choose to disregard those risks, then that would be your choice. But the guidelines are kind of set forth for a very specific reason, and that reason is to keep you safe. I mentioned earlier that previously I've worked as a labor and delivery nurse, and labors and deliveries and pregnancies with twins and higher order multiples like triplets, etc., they're risky. They're very risky. You'll be seeing a high-risk doctor. Lots of twins are born early. They require stays in the NICU. And there's a lot of reasons, a lot of good, strong reasons why we should transfer them one at a time. And so, again, all of that said, if at the end of the day, you recognize those risks and choose to disregard them at your own risk, then that would be your choice. So, okay, let's see here. Oh, I passed up a question. These questions are actually somewhat difficult to follow. Hang on. There we go. Mary is asking, Mary Ness, sorry. I am doing protocol number 3 after 2 losses, and I'm going to assume that that is the immune protocol 3. I have in the past done the estradiol blue tablets vaginally. Someone put on my baseline 2 by mouth, 1 vaginally, but it must, yes, you can 100% do them all vaginally. A lot of times the bottle is going to say to do them vaginally. We sort of transitioned to doing them orally because it seemed to be, in most cases, just as effective, but less irritating to the vaginal mucosa. But in your case, if it upsets your stomach, 100%, you're welcome to do them vaginally. Nefertiti asks, is multilaminar the same as trilaminar, or sorry, multi-layered? And the answer is yes, definitely the same. Christy says, can you remind me again at what point intralipids are used? Kind of depends on your specific protocol. For clients with known recurrent miscarriage or recurrent pregnancy loss, oftentimes we will request or recommend that those intralipid infusions be done right at the beginning of the cycle. So usually at baseline or with the start of your estrogen, and then weekly thereafter. So intralipids, we never want them to be more often than weekly. But weekly is pretty much the indication there. Let's see here. If you have one transfer and it fails, you have to pay off everything before you can have another transfer. Samantha, I so wish I knew the answer to that question, but I do not. So if you could kindly direct that to our financial team, that would be excellent. Rachel is asking, we have a compound pharmacy locally. Am I able to continue the oral progesterone? Okay, so we don't use, I think you're talking about progesterone lozenges, and we don't typically use those. Not that you couldn't, but you're asking if you could use that instead of injectable progesterone. So the answer is maybe. Progesterone in oil really is the gold standard of good, solid, slow, and steady progesterone delivery. And so while it definitely is a pain in the bum, literally, it is highly recommended. With that said, if you want to try without and you want to try oral and vaginal progesterone, some people do just fine with that. And so that's something we could definitely consider. If you'd prefer to do the oral lozenges instead of the oil, certainly something we could look at. And we could kind of look back through your IUI cycles and see how everything looked and see if that might be indicated for an IVF cycle. So that's a great question. Blue is asking, can you do an HCG wash and HCG booster in the same cycle? I've already opted to do an HCG wash and intralipids. Absolutely, you could do both in the same cycle, and many, many clients do. So if you want to do that, what most clients do is they bring their HCG vial to the wash. We mix it. You let them know that let your nurse know that you are going to use the remainder for boosters. So we would mix it, use what's necessary for the wash, and then you would use the remainder of the vial for the boosters. Boosters typically start the day of the transfer. And then we would just recommend, boosters are typically recommended, I believe, through about 10 weeks of pregnancy. It could be 8, but I believe it's 10. So you are going to need several vials to make that happen. But 100%, you could definitely do both. Let's see here. Erin is asking, can I go over the timing of purchasing plane tickets with retrieval and FET? So most of the time, It depends on the age of your embryos. So obviously, if you have day 3 embryos, you're not going to have as much of a heads up as if you have day 5 embryos. But most of the time, you get about a week's notice before your FET comes up. And what we can do is we can always look back through previous cycles and sort of see if we think your lining is going to develop adequately. And if so, we can kind of give you a range of dates. But I do know travel is very, very tricky part of this process. And obviously booking stuff at the last minute is costly. So we'll always give you our best guesstimate of when that transfer is going to happen. But obviously your body's going to be kind of in control of that process. Let's see here. We have time for about one more question here. So let's see here. Let's see. So I suppose... I'm not sure, Christy, I don't think you were the one that asked the question about the intralipids earlier. I try to answer different people's questions if I can, but Christy is asking, so I suppose intralipids can't really be done if you're doing remote monitoring. And that's a really, really, really good question. So the answer is yes, they can be, if you can find a local facility that's willing to do the intralipids. So most of the time, our clients who do their intralipids locally prior to arrival are finding a local infusion center that's willing to do the lipid infusions for them. Now, a lot of times those places are not going to be willing to accept the intralipids that you have. They have a process that it has to come from their own pharmacy or something like that. But you absolutely can call around to infusion centers. So I would recommend checking outpatient infusion centers near me on Google. Just Google outpatient infusion centers near me and just call around and see if you can find somewhere that would be willing to do those intralipids for you. And we do have, I would say, maybe half and half of our clients for whom we recommend weekly intralipids are able to find somewhere locally, and then maybe the other half are not. So it's definitely kind of just depends on the area in which you live and whether or not that's available. But most of those infusion centers are going to require us to fax them the orders directly. And so what I find to be most easy, just because every infusion center seems to want something a little bit different, is to just have that infusion center fax us a request with everything that they want us to send. Because like I said, some infusion centers just want the orders. Others want, a history and physical and lab results and all kinds of other things. So there's a lot of different things that different centers or different infusion centers are requesting. And so I always just say, if you find somewhere, give them our fax number and have them fax us a request with everything they need, and we'll get them. Hopefully that is helpful. That is all the time we have for tonight. I hope that tonight was helpful. It seems like a couple people have made comments that these chats are helpful, and I really like to hear that because I certainly don't want to come and bore you all every Monday night. So thanks for your time. I hope everybody has a wonderful week. I'm sending lots of positivity and love to all of you for successful outcomes. For those of you who have been on this journey for a very long time, don't lose hope. We're going to get there. And for those of you who are new to it, my best advice is to just take some deep breaths and to take information one step at a time, because sometimes if you take too much all at once, it becomes a little overwhelming. So everybody have a wonderful night. Please reach out in your patient portal if you have specific questions. And remember, like we talked about at the top, if you are having monitoring, just send us a message the night before. Tell us where you're going. It certainly does make the process a lot faster. All right, everybody have a great night, and we'll see you next Monday.